Good morning, honorable senators, members of parliament, members of staff. Welcome. Thank you for joining us today. While this is a virtual event, I would like to take a moment to acknowledge that I'm speaking to you today from the traditional unceded and unsurrendered territory of the Anishinaabe Algonquin Nation, whose people have lived on this land since time immemorial. In 1998, Canada declared victory over measles by achieving elimination status. Elimination status simply means that the disease is no longer circulating regularly in our country. It's defined as a lack of continuous transmission for at least 12 months. This success came only 6 years after we first set the goal to eliminate measles in Canada at the 1992 National Consensus Conference, as public awareness grew and parents stepped up to protect their children. For more than 20 years, measles remained a rare disease here in Canada. But today, we're witnessing something very troubling. We now face a significant resurgence, the largest outbreak since 1998. This outbreak is hitting us hard, and much of it can be traced back to the pandemic. The COVID-19 disrupted routine childhood vaccine schedules, causing many vaccinations to be delayed or missed, including measles, mumps, and rubella vaccine. Making matters worse, the pandemic fostered increasing vaccine hesitancy and mistrust in public health measures. If we fail to stop this outbreak, we will soon lose our nearly 30-year status as a measles eliminated country. This is a devastating prospect when you consider the harsh health consequences measles imposes on our youngest and most vulnerable, including things like brain inflammation, pneumonia, even death, especially in young children. In the midst of this growing outbreak, there is understandably a lot of concern over what this means for our communities and for our children. This is why I'm proud to work with Children's Healthcare Canada and Senator Kutcher to organize this session, so that we can ensure parliamentarians are well informed and up to date. The session will provide you with practical, current information on the state of measles in Canada today and what we can do to protect our children and our communities. We are very fortunate to be joined by our panelists here today for this important event. And I'll just take a brief moment to introduce them. Dr. Michelle Barton-Forbes is a trailblazing pediatric infectious disease specialist, researcher, and associate professor at Western University. She serves as head of infectious diseases at London Health Sciences Children's Hospital, where she mentors aspiring healthcare professionals. A passionate advocate for children's health, Dr. Barton-Forbes has spearheaded numerous initiatives, including regional programs for congenital infections and clinics addressing vaccine hesitancy. Dr. Barton-Forbes is deeply involved in research, clinical care, and mentorship, and has received multiple awards, including the Canadian Pediatric Society's Daniel Grenier Award and the King Charles II Coronation Medal. Dr. Paul Roumeliotis, known by his patients as Dr. Paul, earned his medical degree at McGill University and founded the Montreal Children's Hospital as Asthma Center and Pediatric Consultation Center. Dr. Roumeliotis has been the medical officer of health and chief executive officer of the Eastern Ontario Health Unit since January of 2007. The author of many articles, booklets, and videos on a wide range of health issues, Dr. Paul appears bi-weekly on CTV Ottawa's Lives Health segment called Paging Dr. Paul. I'm glad to have Dr. Barton-Forbes and Dr. Paul here with us today to talk about this important topic. And I'll take a quick moment to thank you ahead of time for making the time to join us. At this point, I'll pass the floor over to Dr. Barton-Forbes.
I'm here to talk today on something that I'm extremely passionate about and didn't think that at this stage of my career I would be facing this in Canada. I hail from the developing world where I saw this and other vaccine preventable diseases, but didn't expect to see that today. I'm speaking today, but not from any of the national not from any of the national hats that I wear. Um, And so, um, I want to address measles. So, measles is a highly contagious viral illness, and it is probably the most contagious infectious disease that we see, and it is transmitted airborne. And that simply means that, unlike coughs and colds that are spread by big droplets, measles can spread just from us talking. We can be in a huge arena, one person infected, and if there are vulnerable people, then other people get infected. In fact, if you have 100 people in an arena with 1,000 people, and 100 people don't have any protection, meaning they've never had measles vaccine or measles disease, so they are vulnerable. If one person steps into that arena with measles, the chance is that 90% of those people who are vulnerable will end up getting the disease. So it's super infectious. The other thing that is important to note about measles, why we make a big ado, not only because it's spread and has no borders, once it gets out, it spreads, it also affects, it can cause severe disease in certain populations, particularly in children, especially if they are young children, as well as pregnant women and people whose immune systems are not strong enough to fight infections. And so as a result, we talk about its morbidity. It causes significant complications in these patients, these persons, as well as it's not a walk in the park. It's a disease that can cause significant fatality. And in fact, measles vaccine transformed all of that. Before the vaccine, we were seeing lots of deaths across the world, and it's estimated by World Health Organization that the vaccine in the last 20 years between 2000 and 20, um, it has prevented approximately 31.7 million deaths. So, um, measles vaccine has been eliminated across several countries, as you see in dark blue, um, across the globe. Although, although recently some of those countries have been threatened, there's a threat to lose their elimination status, including the United States. So measles anywhere is a threat everywhere, simply because it's so infectious. And this figure just shows how the success we had as a country, Canada. We saw lots of disease outbreaks before measles vaccine was developed in 1963, and then we improved our approach, and with two-dose vaccines introduced in the late 1990s, we were able to achieve successful elimination. So definitely speaking to the strength of the vaccine. So then if we eliminated measles, why is it then that we're still seeing measles? Well, this is simply because there are countries in the world where measles has not been eliminated, so it's endemic, it's circulating. And in the era of travel, we have lots of persons who have chosen not to be vaccinated. And when unvaccinated persons travel to areas where measles is circulating, they then become an opportunity, a host that now serves to spread the infection to other countries. And so this is exactly what's happening. There are multiple factors as to why we're seeing more and more persons unprotected against measles. So there's this big vaccine hesitancy, which really exploded around about the time of COVID, when people became so concerned about COVID vaccine, and there's a lot of misinformation. This created a significant gap and fall off in vaccine coverage, but as well, the mitigation strategies from the pandemic made access limited for certain populations in terms of getting their vaccines. So a multiplicity of factors put together put us in the rut that we're in. And so with measles surges happening more and more across the globe, and with travel ready, what's happening is that an unvaccinated person who gets exposed flies back to their homeland, and if they happen to get into an area where there is a fall off in vaccine protection, then you end up with a spread. And I'm going to talk a little bit more about why measles is a sensitive marker for picking that up. So this is what has happened. So since elimination, we've seen, sporadic episodes of measles throughout the years between 2000 and 2025. But this particular outbreak is the largest that we've had in the last 30 years since elimination. And you see the size. There was a big outbreak in 2011, concentrated mainly in Quebec. And then there was a multi-provincial outbreak in 2014. But this by far, reaching these numbers now in 2025 is very discouraging for us ID doctors and public health folks. So on the big scale, this is what's happening across Canada. You see the hotspots are really Ontario as a province and Alberta as a province. And those two provinces together are really contributing significantly to the numbers that we're seeing in Canada. And you can see that 1848, this was and Alberta 500, but since that it has gone up, because yesterday Alberta reached 710. So the numbers keep changing with each week. This was at the time that this was released. So how did we get to this outbreak? So really, again, we spoke about travelers going to endemic areas, and they're unvaccinated, so they then become an infected host who now returns. So in this particular case, there was a traveler who was exposed to measles outside of the country and brought it in. And the thing is, measles, often you are infectious sometimes before you even, not sometimes, all the time before you even know that you have the infection. You know that you have the infection once you see the rash, but 4 days before the rash, you are infectious. So some of these people really don't know. They think they just have a common cold. So they would have gone to whatever event. So this particular traveler traveled to New Brunswick and exposed a wedding, a group attending a wedding, and with multiple visitors from different places in particular. So this is what happened. And the story evolved since last year, October. And this is what this snapshot in May 9th showed, that we were seeing measles cases across different provinces. Although I will say that for some of the cases in British Columbia are not necessarily linked to the outbreak that took place in New Brunswick, but the ones in Ontario are directly linked. And so this is what the traveler came in October. It triggered an outbreak in New Brunswick, which ran from October to January. But in that period of time, people returned to wherever they were from in Canada, including Southwest Ontario, and that triggered an outbreak in Southwest Ontario within a community with low levels of protection. And that's the problem with measles. If 95% of the community is not protected, then that community is vulnerable. And so with vaccine coverage being low in the particular community where it started in Southwest Ontario, it spread like like wildfire. And this is where we are now at 1,888, but not limited to the community that it started in. So it's now multi-jurisdictional crossing several public health units. But then we see that in March, this also triggered a set of cases in Alberta, and now we now know that we are up to 710 as of June 2nd in Alberta, and there are a smattering of cases in other provinces, but I chose just to highlight the two big provincial outbreaks. So let's cone in a little bit into what's happening in Southwest Ontario. So in Southwest Ontario, the epicenter, the hot spots were really in the southwestern public health unit areas, as well as the Grand Erie. So so that's where it started, and it spread like wildfire to the surrounding communities in Southwest Ontario. And so from my lens, I started seeing this in the hospital from the end of January, and I didn't think I would still be here in June. A little encouraging though, the epi curve, you can see that there is a trend in that it's falling off in May, and we hope that it will continue to do that. We in April we thought we were getting there, and then we saw another set of, because what's happening is that it's like a forest. It will burn until the forest it's like a forest fire that will burn as long as there are trees available. And so the communities, there are several communities in Southwest Ontario with low vaccine coverage rates, and so it's marching from one community to the next. And the reasons are multifactorial, cultural, religious, etc. So the most latest report last Thursday showed that most units have had a fall off relative to the previous. So in this last column, you'll see that this was the number of new cases as of May 20th, and then since May 20th, you see a fall off in most units except Waterloo and Algoma, where there has been an increase. So we don't know where that's going to go. And this just basically shows the hotspots over time, with red being the hottest. And again, you can see in Southwest Ontario, this is the epicenter. That's in March, what it looked like. It got hotter in April, and then you started seeing areas that were not as hot getting hot. And then this is in May, and then this basically shows you the cases that are really new since the report in May 20th, May 27th. And really the hotspots are really in Algoma and Waterloo. So what do we know? 79% of these infected cases are children and teens. And we did speak earlier about children being a high-risk group. What we also see is that it's predominantly in the unvaccinated. So the message is that this doesn't have to be. If we vaccinate, then we can solve this problem, because it's really the unvaccinated community that's getting this. 95 to 100% of the cases are unimmunized. The interesting thing about this outbreak is that we're seeing pregnant women, and to me, that's from the hospital lens, that's the most nuanced group, because you're talking about not just one, but you're talking about one, at least two or three involved. The mother or the parent, the pregnant parent, and their baby or babies. And so, but babies are high risk groups because their immune system is not as strong. So even though thankfully the numbers are only 38, but we're beginning to see congenital measles, which is something that I never saw in the developing world, because even the ones, most people, even if they didn't get vaccinated, they get natural immunity in the developing world, so that by the time they become at the reproductive years, they don't get measles. So So now we're seeing, because we have a group of people who have chosen not to get, the people who choose not to get immunized, um, the last time there was a significant exposure in the Southwest Ontario, according to our public health unit's records, was 1994 to 1996. And so if anybody chose not to get vaccinated since that, they are now at the reproductive years without natural immunity. And then this, with this circulating measles, they're coming down with measles in pregnancy. And it's not a walk in the park. I'll show you another slide. Um, we're fortunately in this outbreak, we're seeing less than 10% of the outbreak affected individuals being admitted, and that is really quite at least a relief, because we're already swamped with 7.5%, because if you know anything in the hospital, we have to be putting on precautions, etc. So we are glad that it's not more than 10%, because I don't know how we capacity wise we would cope. We don't have enough negative pressure rooms to deal with a whole set of patients coming in with measles at most hospitals. So thankfully it's less than 10%. Some of them get admitted to ICU, a small percentage, and those patients are obviously at higher risk of death, because most of them are having breathing issues requiring oxygen support. Um, Fortunately for us, in Ontario, our outbreak has not been associated with any deaths, but down south in the US, they have had deaths in there. And then coming to the close of my section, I wanted to impress on you why we get concerned about measles. We get concerned about measles because, one, the volume of work it is in the community for public health people, the exposures that can take place, particularly for the immunocompromised patients who have cancer, etc., where the mortality can be as high as 40 to 70% in these populations who are transplanted or immunocompromised, and they are not able to get the vaccines to protect themselves. So they are depending on the community to protect them, the herd immunity. And when we lose herd immunity, in the sense that we don't have people who are responsible and are able to be vaccinated, they are not being vaccinated, it means that we have a hole in protecting the ones who we really need to protect, the cancer, the immunocompromised patients. So that's a big deal. But then even if you don't have cancer or are immunocompromised, you could still end up quite sick in hospital with pneumonias. Pneumonias is probably the number one reason why we're seeing admissions in this outbreak. But in young babies, they can have diarrhea and dehydration. So a chunk of them are being admitted for fluid resuscitation and stuff. We are finding that the older kids tend to have hepatitis. So that's an inflammation of the liver. And so those patients, that's another reason why they come in. Fortunately, we're not seeing that many brain infections in this outbreak, and that it can happen early and late brain infections, what we call encephalitis. I do think that because it's a spectrum, we can have mild cases of encephalitis that may go missed simply because it's self-limiting and they get better. However, the ones that are really concerning will be the late onset brain infections, what we call SSPE, and that usually doesn't happen until 6 to 10 years later. It's rare, but what we do know is that the earlier that you get measles, so children who get measles before 2 years of age have a 16-fold increase in getting SSPE. And SSPE is a fatal degenerate. So basically, you present with seizures, eventually go into coma, vegetative state, and then die. So, and there's no treatment for this. Fortunately, the literature states that it occurs 1 in 10,000 cases. And I just want to put a plug here that whatever numbers you see public health reporting, we know that's a huge underestimate. We say multiply that by up to 5 to 10 times, because a lot of these families have probably 5 to 10 children, and only one might present and get tested and get counted. Some of them are not necessarily telling that they've been through it. Some patients get measles and don't get very sick, so we are not able to test everybody. So the numbers are much higher. So I don't know what this is going to turn out to be in the long run as it relates to what numbers we'll eventually see in another 5 to 10 years with SSPE. And then, of course, something that we don't talk about, but we are now beginning to see is that because measles affects your immune system, you can get more infections after measles, more serious infections. So we've seen meningitis from another bacteria coming on in children who had measles 6 weeks ago, and there are other things that are going to be seen as a result of the measles. So measles happens and they may get over measles, but they may end up getting a more serious infection. And then, of course, there's death. And this slide just quickly summarizes that pregnancy is not a walk in the park. It can affect the pregnant parent in causing hospitalization in up to 60% of these individuals, and they can get complications, including death. We don't have the rate for deaths in the first world country, but in the developing world, the rate may approach 18%. And then, of course, it can cause miscarriages and stillbirths. And even if the baby doesn't get infected, the babies can be born small and not growing well. And then we also have seen in this outbreak congenital infections, which means that the baby ends up with measles from in the womb and presents at birth or in the first 10 days of life with measles. And that in itself, the rates from the literature show that the mortality can be as high as 20 to 50% if we don't give immunoglobulins. So fortunately, we do have antibodies that we can give if the parents are willing to have this, that will lower the rate of mortality in these patients. So that's it for my slides.
You. Go ahead, Dr. Paul.
I'm going to be talking really complementary to what my colleague talked about in terms of, our worry about the measles outbreak and the fact that it seems like we're going backwards, after so many years of eliminating measles. I will speak to you from several perspectives. One, I'm a pediatrician, and I've treated children with measles and their complications for many years. And secondly, I'm the medical officer of health for Eastern Ontario, and as such, I'm involved in all of the public health follow-up. We distribute vaccinations, we see the vaccination trends, and we see some of the causes. And just anecdotally, my health unit is at the eastern tip of the province, and up until 3 weeks ago, we had no cases. And it's interesting, the cases that we had had traveled to the hotspots. And we're from the same community. So it's just to show you how this can spread quite easily. So obviously, and I don't think we can say too many times. I'm going to reiterate, very often I do a lot of media, and I just say, measles is not a viral illness with just a rash. It really has potentially life-threatening complications, which my colleague has explained, and that's kind of the message that we give. I give two messages to the media. Number one, measles is quite serious. And which is bad news. Number two, the good news is that we can prevent it almost fully with vaccination. So those are the two things that the messages that are going out. Again, the facts really have to do with, again, I'm not going to go over it too much, but it's worth repeating. The measles virus is really among, in my opinion, one of the most contagious. One person can infect up to 18 people who are vulnerable. And if you compare that to the flu or to COVID, one person can infect a couple of people. And so this is quite contagious. It can linger in the air for a couple of hours. And so that's one of our challenges as public health, where we get a case and we need to say, okay, where have you been? What's your contact? So that's part of our contact tracing. And sometimes, and I see a lot of that, particularly with my colleagues in Southwestern Ontario, they have literally dozens and dozens and dozens of potential contacts. People have gone to the store, people have gone to restaurants or whatever, and they have to put public health messaging. If you've been in contact, please monitor your symptoms and so on. And then we need to follow up on those children. So it's the leading cause of death in children in developing countries. It was when I was at Johns Hopkins about 15 years ago. 8 to 10 million children were dying per year in sub-Saharan developing countries. And among the top 3 killers was measles. And so even in 2023, although we've eliminated it in sort of developing countries, there's been over 100,000 deaths just in 2023 worldwide from measles. So again, since the availability of the measles vaccine, there has been a significant decrease. And again, the MMR vaccination, we give it really protects 85 to 95% with first dose and almost 100% with a second dose. So again, trying to understand the resurgence, obviously there's the post-pandemic fatigue and as a public health leader, I lived that. We saw that during the pandemic. We shifted in Ontario. For those of you who are not from Ontario, public health units are the ones that distribute vaccinations to primary care and other health facilities. As well, we are the ones that have in Ontario what's called the Immunization Students Pupil Act, where every year we have to have the records of children, and if the children do not have other vaccines up to date, and don't have proof of a medical or affidavit signed, they get an exemption. They actually get suspended from school. And so that's a tool that we use, and it's actually helped us recover from a lot of the decrease that we saw during the pandemic. So, and as well, during the pandemic, primary care access and even post-pandemic has decreased. And certain communities do not vaccinate, and we're seeing it in communities for religious reasons and other reasons that don't vaccinate, and they're the ones that are the most vulnerable. So you can imagine now if one individual enters a community setting where there's 100 people and one person infects 18 and then that other person infects another 18, you can see how this thing has grown. There's also the imported cases. A couple of cases in Ottawa were imported from outside of the country, but most of the cases are linked to the original cases that we're seeing in Southwestern. So essentially, I just want to talk about sort of the causes, because a lot of people have that question, like what's going on? We know, I think my colleague explained to you sort of the history of it and how it occurs, but there's also been post-pandemic fatigue and post-pandemic hesitancy, vaccine hesitancy versus vaccine refusal. I just want to talk a bit about that. When before we went into the pandemic, we talked about vaccine hesitancy and absolute vaccine refusal. And people who absolutely refuse vaccines for one reason or another are about 1 or 2%, a really small amount. Vaccine hesitancy is about 10 to 15% of the population, and that part grew during the pandemic. And so, but the vaccine hesitant, the good news is that we can work with them, and the majority of them will be able to understand the benefits versus the risks, and hence, get vaccinated. So how to be protected? Obviously, persons born after 1970 need 2 doses. The first dose is given at around 12 months, and the second dose is given between 4 and 6 years of age. People born before 1970 are presumed naturally immune because we didn't have a vaccine at that time, and so the virus has not changed much immunologically. So it's we believe that there's a lifelong protection once you get a natural infection. Preventing measles, really, we need to optimize vaccination rates, and so we need to get it up to 95%. I could give you an example. In my health unit, during the pandemic, we went down to 45% of MMR at 7 years of age. And that was, again, because of, the pandemic shift. And so we worked hard with the schools. We did a lot of community clinics, promoted school vaccinations, went to schools to vaccinate children and so on. And we got it up to about 94% right now. So I'm quite happy to say that. And so we need a community-wide effort to catch up. So we work with schools, communities, and so on. The outbreak management, again, what we're doing now is once we get a case and there's a contact, we have to look at who's in contact, and we sometimes in certain areas which have high rates, we have basically an approach where we might give the vaccination a bit earlier to younger children to protect them, or give immunoglobulin. There's a whole slew of things that we can do to prevent infection post-exposure, but there's a limited window during the time we can do that. And really, I think one of the most important things is we need to focus our efforts to work with the communities to foster increased uptake. And that my colleagues are doing. They're going to some of these communities, talking to their leaders, trying to work with them to better understand, the rates, better understand the benefits, and so on. And they are getting some approach, some success in that regard. And then we need to, continue our efforts to address vaccine hesitancy. And at the same time, I lump in countering misinformation. And we see a lot of that on TikTok, on social media. Again, it doesn't help that in the South we have leadership that doesn't really believe in vaccines, always links the MMR vaccination to autism, which is not true. That's been debunked. In fact, there's a criminal investigation in that false report, and that there's no linkage to that. And I think us as public health leaders, physicians, and people in Parliament, people across the country need to be on the same page, really trying to debunk this information and try to be supportive. And I give a lot of lectures on vaccine hesitancy. It really has to do a lot with establishing a relationship. We can't be dogmatic. We can't order people to get vaccinated. We can't be seen as overbearing. We need to be understanding. We need to have a relationship, and that's why very often, it takes a couple of sessions before when you meet a parent. A parent is hesitant. You can explain to them. You can ask what their hesitations are. Go back and forth, and with that, I think we can build it up. And again, it's really a matter of countering that misinformation. And so, just to summarize, it really is an important challenge that we're facing right now. It'd be a shame that we lose our elimination status here in Canada of that. But I think the important thing is that we are seeing, and so we have to understand, okay, like in our area, we have pretty high protection rate right now, but we had a couple of cases. And so the context is that it's not rampant in our community, but it is rampant in communities that are not fully vaccinated. And that's our challenge. And then with the travel, be it in Canada, be it international, that it complicates us as well. And so I think it just takes persistence and looking at how we can better work with these communities, work with those individuals, so we can bring up those vaccination rates to where they should be. That will then protect that 5% of the population. When we talk about 95% herd immunity, we're talking about community immunity, being that if 95% of the population is protected, there's less chance for the virus to circulate. So you're indirectly protecting the vulnerable or the people that don't get vaccinated, or for either for medical reasons or other things, or age. The 5% is protected. So thank you very much. I'll turn it back.
Thank you, Dr. Paul. So we'll have about 10 minutes, I think, for questions. So some of our guests have put their questions in the webinar chat. So if you'll allow me, I'll just read those off, and then I would say either Dr. Paul or Dr. Barton Forbes, if you guys have an answer, please go ahead. So the first one, I'll summarize a little bit, but the question is around, is there a network for communication or a systems that allows data sharing between public health units? The person asking a question is saying that in a school, in their writing, there were teachers who were not cleared to be in the school because they had probably received their vaccine pre-1970. So how do we address those issues?
I can answer that because it's a lot of what we do. There's no vaccine pre-1970, so I think that essentially we're talking about people born before 1970. We presume they're immune. However, the question is there a network where public health units can talk to each other? I'll give you the Ontario context. We have a system that public health units use, and for the most part, we have access to it across the province. That's called Panorama. So when we take all the kids' schools records, we put it into Panorama, and Panorama is accessible across the province. However, there's no national network that provides that, so somebody in Alberta can't access that. But within the province of Ontario, we do have a system, provided they're in Panorama, that all health units have access to. Unfortunately, what the problem is that we don't have access to the electronic medical records of doctors' offices, and so that requires a more mechanical approach to us send them their proof of vaccination, and then we put it in. But there is a system. It's not optimal, but there is a system in the province.
That is good to know. The second question, a little bit along the same lines. I have read that people born between 1963 and 68 may need to get a booster shot because we got an earlier version of the vaccine. You've just mentioned that there was no vaccine between 1970. So what should people who were born in the 60s do, we'll say?
Does Dr. Barton want to take that, or you want me to take it?
So most people who were born before 1970, more than likely have immunity because that was the time when measles was circulating. It's highly infectious, so you'd have gotten natural immunity for the most part.
So no need for a booster shot would be your
No, there
answer.
are some
Okay.
indications. People ask us, how do I know? And again, this is more for healthcare workers. This is more for people who work with high-risk patients. We have an approach where I'm not sure if I was vaccinated. I'm not sure. We can do a blood test that will tell us if they have immunity. And that's more for specific situations, particularly if they're working in healthcare. We want to make sure they're protected. But in general, we presume that people who are born before 1970 have lifelong immunity due to a natural infection.
Okay, well, that makes sense. Another question that I see in the chat from Mr. Mazier, is there a breakdown of who is vaccinated in terms of immigration status, I guess? So Canadian citizens versus any immigrants, students or working permits. Do we know if the immigration system has a verification process for vaccination, I guess is the question.
So most times the verification as it relates to so I can speak like from a pediatric point of view. So immigrants coming to the country as children, they usually have to get their immunization status verified as they go into school, or we have like immigrant clinics to have them catch up, that sort of a thing. As well, immunization checks are done when you are working in healthcare or special fields where there is direct contact with children. But maybe I'll get Dr. Paul to speak outside of that, how widely immunization is being checked for people who are not going into healthcare or not children going into school.
Yeah, it's hard. We don't really collect that data, but I do know that we had when I was working in Montreal, we were looking at all the immigration testing and so on, immigration screening. Vaccination was one of them, and we do have a process of catch up for different age groups, because sometimes we don't know what the vaccination status is, so we start from scratch. So there is a process in place. I know that when we were, as very often in Cornwall, we receive a lot of the people, the asylum seekers and so on. So we go in and screen them with Health Canada, and part of the screening is whether vaccinations are up to date or not. But that's, again, limited to our area. But in general, I'm not sure about other categories.
But I would say, though, that from an immunization standpoint, probably somebody coming from a measles endemic area, even if they were not immunized and they're an adult, they probably, I mean, it's not all an all catch, but they would probably be higher likely to have immunity if they're coming from an endemic area.
That makes sense. I think we have time for one last question. What is the process? I have to pick a question here, so apologies to if somebody's question didn't get answered, but let's do this one. What is the process for catch-up for kids who might have missed vaccines during the pandemic?
Basically, that's what we're doing in Ontario. We essentially each public health unit, and I'll speak about Ontario, and I'm sure it's similar across the country, but in Ontario, what we do is we do have a listing through the schools, because the Immunization Students Pupil Act allows us to have access to all the children's records that go to school, including private schools and others. We do that as well. And so we get every fall, we get the list of these children and we get their vaccination records. And if there's any missing, the parents get notified with a threat to suspend if they don't have up to date. And we work a lot with them. We create our own clinics. We go into the schools, we work with their doctors, we facilitate these children from catching up. And we had a success with that in my area. We went from 45% to 94%. And within a year. So that's it. So it was simply a matter of making sure we were able to understand parents. They work during the day, so we had evening clinics, we had weekend clinics, we went to the schools and vaccinated the children. So we did it. We removed all potential barriers, really, to ensure that they increased their vaccination rates, very, very quickly. And that was done throughout the province of Ontario. Again, there are pockets of the population, however, communities that don't believe in vaccination. So that is a different challenge.
Thank you. I see Senator Moodie has her hand raised. Did you want to interject, Senator?
I'm trying to undo my video on my mute, and they're holding me fast. So I'll keep talking because you're hearing me. But as a pediatrician that works still, one of the things I can say, Dr. Paul, is that the system that you're talking about is a push from public health. On the receiving end, the physician who is taking care of these kids and has to address the catch-up, there is a specific catch-up. There are specific catch-up protocols that we follow to, depending on age and so on, where you are at in the sequencing of your vaccines and so on. The issue that we're facing is not so much whether or not we can catch up, but whether or not the parents now believe it's necessary. They are using numerous sources of information, and I'm going to say in quotation, evidence that they quote to us. It takes an inordinate amount of time to have conversations you're talking about that we should be having. It takes an inordinate amount of time to be doing this, and frequently at the end of it, you don't get compliance. So we have a bigger problem. The problem is centered around misinformation. The problem is centered around people feeling now increasingly that they're making their decisions, that they have the evidence that equips them with the ability to make medical decisions. And so this is the challenge, is on the ground. The translation into success is not as high as we'd like it to be.
I fully agree, and what's the last point in my slide was really misinformation, and that wave of change of people feeling empowered to make their own decisions. And again, I think the pendulum has swung one way, but I believe it's swinging back this way. But it does take time, Senator. I agree with you. It is quite cumbersome, but it is worth doing. And that's why I'm asking for communities, community leaders, politicians to be on the same page so we can all be saying the same message. So wherever they go, they can hear the same message.
That's a good message.
And to also see a push for this national sort of registry where we can actually see, as physicians working in institutions, sometimes we don't have any idea of who has what, but at least if there is some repository that we can go to and say, oh, well, the vaccines were given. This is something that I think from a political point of view, or from leadership point of view, you guys could help us push this agenda.
Enough. That's a good closing comment. We are 3 minutes out from the end of our event, so I would actually like to turn it to Senator Kutcher for closing words. And I just want to say thank you to our panelists for having taken the time to be with us today.
Thank you very much, everyone, and thanks to our presenters and everyone who participated in this session, and a special thank you to our staff who put this together. It takes much work on your part, and we really appreciate that. It's prescient that today's Washington Post had an article on measles spread in airplanes, warning people about this, and their one important piece of advice was get vaccinated and make sure that your vaccine status is up to date. I'm going to take this to a slightly different level, but from the comments that we've had already. Measles currently, I think, is the canary in the coal mine. And recently I published a paper in World Public Health talking about the threats to global health security. And what we are seeing is an all-out assault on global public health, some of which is aided and abetted and even promoted by political leadership, clearly Mr. Trump, the disinformer in chief, but also, frankly, in our own country, by people raising issues about the WHO, the legitimacy of the WHO, and if you're on social media, you'll see attacks on the WHO constantly, and so the so-called Pandemic Preparedness Treaty, which is supposed to take the sovereignty of nations away. No such thing. But we're starting to see that more and more and more. We know that much of this comes from our neighbor to the south, and what we are actually seeing, and I'm not going to mince my words here, is that we have gone from misinformation to weaponized disinformation. People here may know about the Children's Health Defense Organization. You may know about the Make America Healthy Again report, which came out last week, which cited research papers that did not exist, and the nonsense was just made up. And RFK Jr., the Health and Human Services Secretary in the US, is anti-science, an anti-vax grifter, and under his leadership, most recently, the US has stopped its work on the HIV vaccine, and this week, under the Children's Health Defense, an all-out attack on mRNA vaccines has just surfaced. So we are in the early days, as I see it, of a full-out, well-orchestrated, and deeply funded attack on the essential foundations of public health, replacing it with ideology, wellness farms, and raw milk shooters, as if some of you may have seen yesterday on your social media. Sadly, we have not seen a robust national response from our federal government, nor from the medical community, and we are really missing that. That is why everybody's participation here, either as a presenter or part of the group, is so important. Canadians need to know what the best available scientific evidence is, and they must have trust in our public health institutions. Parliamentarians are in a position of trust, and we have the opportunity to support the best that public health has to offer. So I want to thank all of our colleagues for taking your time to become better informed on this topic so that your constituents, and indeed all Canadians, can have trust in you, that you are there to help them understand these issues better. As always, Senator Moodie and I, along with our Senate Health Group colleagues, are here to assist in any way that we can. So once again, thank you all for your participation, for this really, really informative discussion. I'm a physician myself, and I have to say I learned some new things today. So you've made my morning from that perspective, both our presenters. So goodbye, bonne chance, and good day to everyone. Thanks again.